Thank you, everybody, for joining us today. Before we get started, my name's Jenny. I am HeartLife's Community Engagement Manager, also 4-year heart failure survivor, and thriving with heart disease in remission. We're very happy to have you all here today. Thank you so much for joining us. Before we get started, just a little bit of housekeeping. Just a reminder, please put all of your questions in the Q&A section so our speakers can speak to them once we get to that point in the webinar at the end. Today's session is being recorded and will be posted on our YouTube channel afterwards, so you'll be able to revisit, share, and feel free to reach out after the webinar if you have any more questions. We'll be happy to include them either in next webinars or even in the descriptions going forward on YouTube. We're excited to be launching HeartLife's new E3 webinar series, Educate, Empower, and Engage. This is the first of 4 webinars we'll be hosting each year, designed to highlight key topics that matter to our community. I'm also delighted to introduce today's moderator, Anne-Marie. Anne-Marie is a patient partner, peer support leader, and communicator who is passionate about improving patient experiences and outcomes by translating knowledge into meaningful tools, resources, dialogue, and support. Since 2015, she has worked closely with the University of Ottawa Heart Institute and is an active patient partner, co-creating patient-facing resources, advising on engagement strategies, and helping integrate lived experience into care and research. She also hosts the Ticker Talk podcast for the Cardiovascular Network of Canada and has moderated many in-person sessions and online webinars for the University of Ottawa Heart Institute patient community. Anne-Marie is excited to bring her expertise, passion into the HeartLife space as a part of our new E3 series. With that, I'll hand it over to the lovely Anne-Marie to get us started.
Thanks so much for that intro, Jenny. Welcome, everyone. Excited to be part of this webinar series and to kick us off with this webinar today. So it's a beautiful day here in Ottawa. I hope that wherever you are across Canada, that you are also enjoying some lovely weather. And if not, you have some kind of fun and exciting things to do inside that don't need nice weather. So I'd like to just take a moment to introduce, today our topic is inflammation. And it's a really hot topic these days. There's lots out there in the world about inflammation, what it means, what it does, and what to do about it. So we thought that this would be really timely. And we've got with us, we're fortunate to have with us 2 speakers. Dr. Katey Rayner is the Chief Scientific Officer and Vice President of Research at the University of Ottawa Heart Institute. She's the director of the Vascular Inflammation and Metabolism Lab, which studies how microRNAs alter the expression of key genes involved in atherosclerosis and other chronic inflammatory diseases. As a basic science lab, the lab uses animal models of human disease, in vitro assays of inflammation, cholesterol homeostasis, and cellular activation. I hope you can't hear my dog barking. She does not see patients in her day-to-day work. So just wanted to let, I don't know, for the folks who are on the call, just wanted to let you know that she is what we call a basic research scientist. So she's also a full professor in the Department of Biochemistry, Microbiology, and Immunology at the University of Ottawa. She leads the Ottawa Region Strategic Research Innovation Cluster on Vascular Inflammation and Metabolism. And given her expertise, she sits on numerous boards and peer review committees, as well as being an editorial board member for a number of journals. So lots of important connections and relationships there that hopefully will lead to a really great talk today. Also with us is Francine Poisson. Francine is a patient with lived experience, a wide range of lived experience, as she will share with us today. She has also been a caregiver to friends and family with chronic conditions. Since retiring from running her own business several years ago, she's turned her attention to caring for family members, being a Women at Heart peer support group leader, so inspiring women with heart disease to take action to reduce their future risks, teaching fitness classes to seniors, contributing to community initiatives such as seeking a heritage designation for the part of the world where she lives, and her garden. She is passionate about finding meaning, and inflammation has been a topic close to her heart for many years. So, welcome to both of you. We're excited to have you here as part of this launch, and I'm going to hand it over to you, Francine, to share a little bit about your story.
Well, hello everyone. My name is Francine. I'm 65. I grew up in Montreal, moved to this part of Ontario in 1999. And this part of Ontario is on the St. Lawrence River. It's about 15 kilometers from the Quebec border. So my adventure with inflammation started in the 1990s. So I was a baby back then. I was only 30s, in my 30s. And I was experiencing severe joint pain. And so getting the swollen knuckles and a lot of redness and it was becoming not just little acute, it was seemingly becoming quite chronic. Went to see a rheumatologist. They ran a pilot test to see if it was rheumatoid arthritis. It was not. But any of the meds they tried giving me were really quite ineffective. So we roll into 1995, and at that point, it was quite crippling. I had to take extended time off work. And my doctor at the time decided maybe what we should try is an elimination diet. So I was feeling fairly confident, having grown up in a house with a mother who was a nutritionist. So we'd never had processed food. We didn't have refined sugars in the house. So I thought, oh, I'll probably ace this. Well, it turns out that my body did not like gluten, did not like dairy. And I discovered a little bit later that I couldn't drink beer. That also was instant swollen knuckles, the whole thing. I drank wine for a bit longer, but that soon had to go as well. So alcohol was gone by the end of the 90s anyway. And so the whole food piece was interesting. And for anybody who's done an elimination diet, it takes a while to really flush out the things you can and can't eat. So for me, it felt like it wasn't too bad. I can continue eating the way I was, but get rid of bread, get rid of dairy. And I don't know if you know, but back in the 90s, it was challenging to find gluten-free bread. It was challenging to find a milk or milk-like product that wasn't milk. So I had a friend in Vancouver who would send me goodie boxes. My mom, the nutritionist, figured out how to make me some breads that didn't have gluten in them, but pretty much it was like eating cardboard. So all breads kind of disappeared until more recently. So I motored along for the next 15 years or so thinking, wow, okay, I've got this, I'm doing okay. And then the 2010s arrived. So I'm now just 50. 2010, I'm in a car accident. 2012, I have a hysterectomy. 2014, gallbladder removal. 2016, breast cancer. 2017, chemo radiation year. And then 2018, they put me on, the oncologist put me on tamoxifen, and the number one side effect was weight gain, so that happened. So I was quite glad to see that decade gone, because I really was feeling like I was the poster child of inflammation. Like, what else could possibly happen? Well, I shouldn't have asked that question. So the poster child for inflammation, there I am. So the other thing I realized in this whole thing, it wasn't just about nutrition, and certainly more information about inflammation was coming out. So there was the stress piece, there was the sleep piece, there was the trauma piece, there was the exercise piece. So the exercise piece, that's been a constant in my life forever. The stress piece, there was a lot of it. Yeah, there was a lot of it. Sleep piece, I thought I was doing okay. And a little bit later, I'll tell you why I really wasn't. And the trauma piece. So if I look at that and I go back to the 90s, in 1993, my aunt, my favorite aunt, was diagnosed with terminal cancer. She was given a few months. So my mom and I and my aunt decided we're all going to move in to mom's house and we'll look after my aunt. She only has a few months. So I think we were having such a good time that she lasted. So from August 93, she passed away in June 94. But that was a really interesting experience, but certainly not easy. And you're working through that. And anyway, it was a great education, but fairly traumatic. And then before my 2010s, in 2009, my very best friend at the time had melanoma 10 years earlier, and then it came back with a vengeance. And within 10 weeks, she had died. So lots of trauma, lots of stress. And I'll be honest, I was a workaholic. So that I now get it, really didn't help. So then the 2020s roll along. And in 2020, I guess I was lucky because all of this happened before everything shut down. And my mom has now dementia that's getting a bit more pronounced. She's living in a little home not far from where I live. So it was great. I got to see her all the time. She'd come to my house. So in 2020, I'm walking my dogs just before I go to the fitness class I'm teaching. And I have like the chest pain, the sweating, the jaw, down my arms. I'm like, oh, I'm having a heart attack. Drag myself home. So I go through the rigmarole of tests, and it turns out I have an arrhythmia, and I guess it's a PVC, so premature ventricular contraction, and I get put on medication. But all of this happened at this point. Shutdowns were happening, so I was lucky to get my Holter done, stress test done, the whole thing done. And to come back to the sleep piece, I always figured I was a really, really good sleeper. But I was really tired since the whole cancer business. I was tired all the time and just, I'm thinking I'm sleeping for 8 hours, but I wake up and I'm exhausted. I could sit down after breakfast and fall asleep. So my doctor said, we've tested a bunch of different things. Maybe you have sleep apnea. Let's send you for a sleep test. Well, it turns out it's a good thing I went for the sleep test. And she phoned me when she got the results and said, so you have severe sleep apnea. And I'm thinking, oh, severe. And, I'd looked at the chart and I'm thinking, oh, wow. Yeah, okay. Yeah, she said it's really, really severe. Like, you're my worst patient. And I thought, come on, how bad can it be? Well, the magic number was 71. So it means that 71 times in an hour, I'd stop breathing. So the impact, 1, on my sleep, and 2, on my heart, and who knows how long this had been going on. I suspect for a long time. So got the machine, everything is fantastic. I'm finally sleeping better. This summer, more heart issues pop up. So if I summarize all of this, as far as nutrition is concerned, I feel like I'm making the right choices in terms of what I'm putting in my body. But a good friend was questioning whether I was eating enough. And of course, trying to lose this weight has been impossible. So my doctor said, stop stressing about it. You're fit, you're blah, blah, blah. And how you can sign up to those things where you keep track of how much food you're eating and how many calories you're burning, because I have a fancy watch. And wow, I was really under eating. So I should have been a stick. I should have been much thinner based on this input output, but it wasn't working out that way at all. So when I started eating more and certainly really concentrating on protein, um, I mean, it's not a fast weight loss, but I am losing weight, um, and certainly feeling better. So that was an interesting little mind meld. Um, and the exercising thing, that's always been there. So now what I'm experiencing with my heart is, like if this was a bad heart moment, I couldn't talk because I'd be winded talking. So that's what's happening. So I've had days, if I've overdone it one day, the next day, you can hardly do anything. So I'm currently being tested to find out what's going on. So, Katey, to you, I want to know, so what do we know about inflammation and how does it impact everything I've been talking about? And the other thing, you know, am I doing everything I can be doing? And I imagine in your talk, you'll be able to point me and us in the right direction, because I really don't want to be the poster child anymore. Enough of that. Thank you.
I love that segue and handoff. I think that's fantastic. So thank you, Francine, for that story. We had, of course, had not ourselves connected before this, but I think it actually is really nice the way that I've actually set up the presentation, so that I think we'll see some links. Thanks everyone for the invitation to be here. While we were talking, I put up my background, Taylor Swift's latest album. And the reason I did that, because I'm a huge Swiftie, I'm also wearing a t-shirt, but also because I think it's safe to say we're all maybe in our inflammation era. And I think, there's a lot to learn about what inflammation is doing and what we can do about it. There aren't magic wands. There aren't single solutions. Francine described, I think, the complexity of inflammation in the heart and in the blood vessels. But nonetheless, I will try to give an overview of why inflammation is so important in heart disease, and hopefully give some hints, either what's to come in terms of research and knowledge, and also some of the aspects also that Francine touched on what we can do about it. So just to make sure we're all on the same page, the most common form of heart disease is coronary artery disease. That is the blockages in the heart. So these are, the arteries that feed blood to your heart, are indicated in red. So these are the major vessels. This is, of course, a cartoon, but what we are not seeing is there's, thousands of tiny little microvessels as well that feed blood all over your heart. And then over time, blockages or the actual disease that causes these is coronary artery disease, which is caused by atherosclerosis. Even I have trouble saying that. We tend to abbreviate it sometimes just athero because it's a little bit easier to swallow. That blockage is what reduces the blood flow to the heart. That can happen little by little over time. That usually causes the heart to have difficulty when things like exercise. You might get chest pain when the heart demands more blood. Again, that can cause the heart to enlarge over time as well. And then eventually the muscle itself kind of tires and has kind of difficulty contracting. And that ends up being sometimes what leads to heart failure. Ischemic heart failure is what that's called. Sometimes the blockage itself breaks open or breaks a little bit, and there's a clot that forms that completely blocks the artery. That's a heart attack. That's when, and if it's in a, you can imagine if that happens here, that would reduce blood flow into a major area in your heart. Sometimes that might happen way down here in a tiny little vessel. There might not be any symptoms at all, but that one little region might be affected, might die. Like in this case, you can see in this cartoon, this black here is dead, dead tissue, and that's what happens. So these are just the terms of kind of what we're going to talk about. There are many types of cardiovascular, conditions, dysfunctions, etc. We heard about arrhythmias. There's various types. So this is really only talking about one, but it is one of the most common and one of the ones that leads to the most significant amount of disease in Canada. So this is what these arteries look like. If you slice through them, this is actually from a human heart, and the blood flow is only left. This is the only room left for blood flow. If we were sectioning through that artery feeding the heart, all of this is the disease. This is the atherosclerosis. It's lots and lots of different kinds of cells, and I'll talk about that. And there's all this dead debris in the middle that's called necrotic core. Necrosis just meaning death. But you can see there's not a lot of real estate left for blood to flow in this artery. So that's kind of this is the disease that we're studying, the disease we're trying to prevent, the disease that we want to reduce as much as possible. We can look at this at a real molecular level. So I do want to note in the first slide in the cartoon, it's kind of depicted as this yellow gunk, this blockage that's just yellow. It's not just it's cells. It's full of cells. Again, you can kind of see here in this, all these little dots are cells, but now when we zoom in on the molecular level, these are different kinds of immune cells. And this is again in that plaque, which is, a part of this area right here. So there's tons and tons and tons of immune cells in this artery wall. And just to orient you, this is the normal artery wall, by the way. This is the normal part of the artery, and this is all the disease part. So just to make sure everyone's on the same page. So what are the risk factors for heart disease, for coronary artery disease? Probably most of this audience knows, but just in case, on the left are what we call modifiable risk factors, smoking, high blood cholesterol, inactivity, etc. On the right are the risk factors you can't control, things like your family history, that's also known as genetics, right? Your gender, your ethnic background, obviously your age. It's not that they don't crosstalk with one another. Of course, your gender influences your, for example, blood cholesterol levels or blood pressure levels. Your genetics influence, sometimes even, your smoking status is highly influenced by your genetics. So it's not that there isn't crosstalk between them, but we certainly can't control our genes, but we can control sort of what we do about them, right? So that's kind of how we divide it: modifiable, non-modifiable, or control, non-control. Cholesterol is the number one risk factor, elevated levels of cholesterol in the blood. And I'd say that what I'll tell you today is that the other factor that is not sort of depicted traditionally is inflammation. It's harder to measure. There's not a single test that we can do to test whether or not you have inflammation or not. So it's not right now sort of as widely used, although that's changing. But that is sort of the factor that should be on this puzzle. So why is cholesterol so bad for us, first of all? And that leads to the inflammation, at least part of it. So this is again sort of that cartoon of the artery that we showed an actual picture of earlier from an actual heart, but this is the cartoon version of it. This is kind of the normal blood vessel wall. This is kind of the underneath part that contracts when your blood vessels need to give more or less blood. These little yellow dots are the cholesterol that's floating around in your body. So over time, notice it says preteens, this is young, this cholesterol in your blood can become trapped in the space in your arteries. It's definitely not supposed to be there. We need cholesterol everywhere. All of our cells need the cholesterol. So it's not that cholesterol, all of it is terrible. It's that we generally have way more than we need, almost always. So when this circulating cholesterol in your blood gets trapped, that starts to actually get the attention of immune cells. And I'll tell you in a second why, but essentially this is an immune cell floating around in your blood. Our blood is full of immune cells all the time. It should be. It's always looking for damage and danger, infection, etc. So an immune cell now sees this cholesterol that really shouldn't be there, it starts to eat it up and try to get rid of it because it's not supposed to be there. And an immune cell is a very good, soldier against all the things that shouldn't be there. And that, again, I'll tell you in a second why, leads to more inflammation, more immune cells, growth, 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 growth. So you can see preteens, teens, beyond. So if you look at almost anyone's arteries, even in their again, in their 20s or whatever it may be, there are many different, many areas where plaque has grown. So this is something that, can you guys see the Teams messages that are popping up on my screen or no? I'm just getting these like Teams notifications. Can anyone else, is that bothering anyone else? Okay, just checking, because I don't mind, but I can ignore them. But if it's you guys that see it, I'll stop. But so yeah, so this builds up. So why is the cholesterol itself inflammatory? And that's because our immune cells are really good at recognizing bacteria and dead cells. That's their job. That's their number one job. Humans are complex, and we've got a very good immune system. That's why we're actually able to survive as long as we can. That's why we're able to face so much sort of developmental advancements. But those bacteria here on the right, this is a pneumonia bacteria, and this is a dead cell. They look a lot like LDL cholesterol. That's the cholesterol we carry in the blood, the bad one. This is an LDL cholesterol particle that's been modified slightly by its environment. And now all of a sudden, our immune cells can't tell the difference. Our immune cells can't tell the difference between a dead cell or bacteria, which it should clear. It should get rid of those things, versus an LDL particle that's accumulated in the blood vessel wall. And that just sets off a chain reaction of all sorts of different positive feed-forward inflammatory loops. So essentially, coronary artery disease is an immune reaction to cholesterol. So back to the cartoons here, again, in this sort of blockage that grows over time in the artery wall, there's those little LDL particles, and that's just going to recruit more and more immune cells from your blood to feed forward. And then, I truly could give an entire class on each and every one of these factors. I do, in fact, give entire classes on all of these factors. But there are molecular signals across every single one of these steps that we're just figuring out. The basics are your immune system, your immune cells come from your blood, or your bone marrow and your spleen. They go into the bloodstream, and then from there, they get stuck in the blood vessel wall because of this reaction to cholesterol. So that's why and how the plaques grow. So how do we treat atherosclerosis? How do we treat coronary artery disease? We know we can remove those modifiable risk factors. We can quit smoking. We can increase movement, diet. Of course, we already heard about reduce stress, blood pressure, cholesterol, diabetes. I mean, there's medicines for lots of these things. I wish there was a medication for stress, but more or less, we can modify all of these things. Just a side note, if I could go back one slide. What's very interesting is you can watch and measure stress actually causes immune cells to leave your bone marrow and go into your blood. And so that's part of the reason why stress contributes negatively to the growth of this disease, because the more immune cells you pour out of the immune organs into the bloodstream, the more they're going to grow and cause damage. So that's part of the reasons. Also, disrupted sleep. Disrupted sleep does the same thing. So you can interrupt sleep. You can actually measure this in humans. If you have lots and lots of wake cycles, you see these pulses of immune cells in the blood, which again feed forward to all of these things. So it's kind of a link why so many of these factors end up worsening disease in our hearts. Okay, so I mentioned lifestyle, again, the medicines, LDLs, treating blood pressure, diabetes, all of these things are how we can control the very least things that tend to be, that you can medicate. If a heart attack or a blockage is identified, we can, and this is again, cartoon format here, a catheter can be inserted. I don't do any of this. I'm not an interventional cardiologist, but they tend not to do the femoral artery anymore, but they snake up a catheter from the artery in your arm into the heart here. And so then it lands here, and this is the disease, and they can blow up a balloon and place a stent, which is how it props open that blockage. And this would be the dye injected into the heart. The dye, you can see this artery. You can probably see there's like blockages here, narrowing, and a really bad one here, right? And then the stent is put in, and then now that opens up the blood flow in that area. So that's how we mechanically open the artery wall that has the blockage, and that's kind of how we treat kind of current. This is, we have it in front of us, and in addition to all of the other lifestyle and other medical therapies. But we're here about inflammation. So essentially, when someone is has known cardiovascular disease, so you've either had an event or there's been some symptoms or something like that, so you've had sort of a workup, let's say. There's a couple different things. As I mentioned, there's a list of things that medicines you're going to be potentially put on if you have high LDL. And in this case, in Canada, we 3.8. I think that the number now is maybe about 3.4 or something like that, is an elevated level of cholesterol. And if that's the case, you'll be put on a statin drug, like Lipitor, those kinds of drugs. But there's another marker of inflammation in your blood called C-reactive protein, or CRP. It's more and more measured. It's not standard to be measured, but more and more it's being suggested that this be measured. So if you've got this CRP marker in your blood that's elevated, you're going to be put on a statin, as I say. If the statin works, let me go backwards. If the statin doesn't work, if you don't respond well to statins, your LDL cholesterol may still stay elevated. And 2.8 is, not that low. It's not that high. It's working a little bit, but it could be lower. You may be put on additional LDL lowering medication, drugs like ezetimibe, drugs like a PCSK9 inhibitor. So these are ways that we can further lower your cholesterol. And however, if your LDL cholesterol does respond well to a statin, so it comes down to this 1.8, this kind of nice and low number, but your CRP levels stay high, that's what we call residual inflammatory risk. So it's sort of, even though your cholesterol has come down. So again, coronary disease is an immune reaction to cholesterol. But even when your cholesterol levels are lower, we can still see that the inflammatory markers in your blood are not lower. So it's what we call inflammatory risk, or residual inflammatory risk. And essentially, this is sort of saying, if we know all the things that cause heart disease, if we lower all of them, we should always be able to cure it, right? And we know that that's not quite the case. There's all of these things where you might achieve lowering of one thing, but you might actually still have something else. So it's kind of why we can look across even our own experiences or those of people in our family or friends where one solution works very well for them and another solution, doesn't. So this is, again, very relevant to what Francine just presented. Are there links to other inflammatory diseases and heart disease? So essentially, why would someone have residual inflammatory risk? Why would that be? And again, besides things like genetics and other things, there are other inflammatory diseases that will cause your body to have more inflammation. And here's just your odds ratio, meaning your kind of increased risk, the chances of you having these events compared to someone without this disease. So if you have osteoarthritis or rheumatoid arthritis, you can see that MI is a heart attack. Not sure what CVA is in this case. Actually, I'm trying to think of what CVA could stand for. I'm not sure. This would be either chronic heart failure, depending again on what the acronyms are, or death from cardiovascular disease. So meaning congestive heart failure, sorry. Or, all of these things essentially indicate that if you have osteoarthritis or rheumatoid arthritis, these may be contributors directly to cardiovascular disease. So not just the disease that you're experiencing. And this is why, but I won't go into the details. Infection is also, infection is also linked to increased residual inflammatory risk. Sorry, 1 second. My thing is not advancing. There we go. So infection in whether it be periodontitis, so in the mouth, different infections such as pneumonia, all these types of things have been associated with increased inflammatory activation in the body that leads to more of those immune cells, more of that feed forward. And again, here's that cartoon of this plaque that's growing. And I mean, there's kind of just, again, a feed forward loop. Pneumonia is very interesting. We're actually working on this in my lab. You have an immediate risk, increased risk of developing some sort of cardiovascular event about 30 days within a severe pneumonia infection or pneumonia episode. And even up to 10 years, your risk remains elevated. And we've got some ideas about why that is, but it's actually, it's very, very interesting. And essentially, it's all just, triangulating on inflammation. So all these infections are certainly associated statistically in the population with increased risk of infection. So the only currently approved medication for coronary artery disease that targets inflammation is what's called colchicine. I think in Canada it's got a brand name. I don't remember, but it's called colchicine. Colchicine is actually normally used to treat gout. It's not. It's sort of its number one action. Colchicine actually, there's many different potential mechanisms why it does this, but one of the things is it really prevents the immune cells from becoming fully activated. So by having this drug on board, those immune cells, when they see those cholesterol or other types of inflammatory activators, they're not able to fully mount the inflammatory response. There's been, for a good number of years, there's been there were really positive clinical trials with colchicine. There was just one late last year that showed no effect of colchicine on sort of number of events, so to speak. So, it's mixed. It's still approved for use in Canada. But, as we know more, it may turn out to be that we need maybe a more specialized approach. Maybe we don't just treat people with broad inflammation measured by CRP, but maybe there are subsets of those individuals who might benefit more. So other types of things that, again, are not sort of widely used, but are mechanisms to reduce inflammation. Fish oils, essentially, not just any fish oil, though. The most effective type of fish oil that has been shown to reduce cardiovascular events, so heart attacks, strokes, and those kinds of things, are in this particular form. It's a drug called Vascepa, but it's an icosapentalyl ethyl, which is a specific kind of fatty acid at a very high dose. So it's not just eating a lot of fish. It's not just mixing, fish oil capsules. It's a very unique type of fatty acid that is used, that can be used specifically to treat inflammation and subsequent cardiovascular. The reason is that it's not fish oils. Fatty acids can be easily modified by your body. And so you really need to be careful, because some of them actually become pro-inflammatory if you're not careful. So some of the data about fish oils is very mixed from a nutrition point of view, because the source and type and sort of how much you had and what are the other modifications can actually be very mixed. But the data is pretty clear. There's about a 30 to 40% reduction in all sorts of events when this drug is on board. Again, in people who already have low cholesterol. So they already have those traditional risk factors controlled. This is on board. So this is something, that's, again, not sort of widely used, but it's becoming certainly of more interest as we learn more. And, essentially where we want to get to is I think most of our time right now has been spent focusing on not progressing any further. So stopping disease where we kind of can catch it. We don't want plaques to get bigger. We don't want them to become unstable and cause those heart attacks. Obviously, we don't want them to cause reduced oxygen flow to the blood. But in fact, as we learn more, the more we lower cholesterol, the further we go for longer, the lower we go for longer, the better. As we continue to decrease inflammation and we actually promote healing, plaques is the word that we use for these things, they can actually get smaller. So you don't just stop it and maybe stabilize it, but we actually can start to, have them disappear. This might be wishful thinking, going from something like this to something like this, but certainly this would be the goal, would be stop. We don't want to just stop it. We want to actually shrink it. And then, we I think be in a much better place to be able to sort of have confidently say that we're healing these hearts, and we're not likely to see any more damage or disease. So what can I do? I mentioned things like colchicine and the fish oils, the IPA or icosapentalyl ethyl. It's not again, those are sort of not widely used, and physicians have very like I have an opinion. I'm not a physician. Guideline committees have their opinions. Different guidelines across different countries have their opinions. Trials tell us new things. As trials come out, even physicians will say, "Yep, I knew it. I'm not going to use this." Others say, "You know what? I still think it's worth trying." Those kinds of things. So there are these medical options. We already heard from Francine about all the good things that the rest of your environment do for inflammation. It's really amazing how much these sort of healthy lifestyle, so to speak, factors can influence inflammation. It's actually very shocking to see some of the effects of these things can have. So prevention on the left, treatment on the right. There are some, as I say, coming on board, these treatments for inflammation directly. But as of now, the best thing is managing through lifestyle and managing through taking existing risk factors under control as much as possible. Diabetes is very, very, very inflammatory. Very, 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 very. So high blood sugar, chronically high blood sugar has a real, really, really activating effect on the immune response. So those kinds of things, in addition to what I talked about today with cholesterol, are really critical. So I'm going to stop there. I'm going to stop sharing so that I could see everybody, and happy to take questions and comments and anything else anyone likes to say.
All right. Thank you both so much for your presentations. Francine, you've certainly been through the ups and downs of life in a big way, and definitely no stranger to inflammation and what that might be, what that might be doing. And Katey, some of the insight that you shared about learning things. It was new to me that basically cholesterol, the inflammation, and how cholesterol and inflammation work together or happen together,
Mm-hmm.
and what those relationships are. So really, really helpful. Thank you. There are a couple of questions about other things that might trigger an immune response or an the immune response. So would leaky gut and COVID and long COVID, would those also be conditions that might trigger that inflammatory response?
Mm-hmm. Yeah, infection is a huge one. COVID directly, because we have there's during an infection we have lots of immune cell responses, etc. COVID is actually been found to be inside of the artery wall when after and inside of the heart. So the actual virus in that case is also producing an inflammatory response in the heart directly. Most infections, it's less about the infection reaching the arteries. It's more about the immune sort of activation of those cells. Yeah.
Okay. And so by reducing the inflammatory response, so you talked about how the relationship between the immune response to cholesterol causing the inflammation, right? Do I have that right?
Yeah.
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 So what the immune response to other things like pneumonia, like another infection, is
Mm-hmm.
that generating the same process in terms of how it's impacting your cells and your body?
Mm-hmm.
Yeah.
Yes, basically, like it's like fundamentally, yes. There are some really specific things that happen because cholesterol itself is not a foreign substance. When it's ingested by the cells, it's actually like it's able to be used essentially as fuel. Cholesterol is a type of energy source for our bodies, unlike, a virus would be, let's say. So there are some sort of molecular cross points between the different types of inflammation triggers. But the fundamental, if we were to try to measure that just in the blood or, it would be really hard to tell the difference. That's kind of why we do work in my lab trying to do those molecular dissections. We have these comparisons because we would much rather take the molecular activation that cholesterol produces versus one that infection does, because it'd be much better to leave the infection side just fine, right? Versus the one in response to cholesterol. So there are differences. We don't know them all, though. I mean, at the end of the day, that's kind of like it's what's driving us to try to make some sense of these. It doesn't make any sense why our immune cells react to cholesterol. Like, why would it do that? But it's because our immune system is really quite primitive. It really just wants to protect us at all times. And we did not evolve in a time with high cholesterol. We did not have food sources. We did not have, the different types of things. And it doesn't mean that if you stop eating them, it all goes away. It's that our bodies have these reactions because of our evolutionary pressures. It's not as individuals we have them. It's that as a species we have them. So it's really hard to turn those evolutionary, things off, because we were meant to conserve our cholesterol as much as possible. And we were meant to, that's why we have fat tissue, is because we used to go through periods without food for a very, very, very long time. And that's how we survived. Now we know our foods, are not fewer and further between. We don't need those stores, but our body's really, really good at them. Sort of the same with cholesterol.
Okay. A couple of questions about food choices. So, someone who has been working on getting healthy after radiation and making a whole food plant-based diet. And also, are there, also the flip side of the question is, are there particular foods or diet that would be good?
Yeah. So there's no magic food. There's no, if anyone's trying to sell you pomegranate extract or antioxidants or any of those things, it's usually selling a bag of goods. What is true is that many of our foods, and I stop short of saying ultra processed foods, because as I learned, was sort of made aware recently, even, almond milk is an ultra processed food because it's been processed, right? So, but that's not the same as, a Pringle or a potato chip, right? So so we have to be careful of lumping it all together. They're not all bad, but in the case of foods that really are are far, far, far from their sort of original ingredient, and or have been just kind of constructed in a way that particularly those high in sugar is very, 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 and not just sugar, but carbohydrates are very easy for your body to digest. They do produce kind of these spikes in glucose, and I there's such a what's the word, a dangerous field out there with supplements and selling and all those things. And I tread very lightly to say that those are there are no solutions like that. However, wholesome foods of plant-based origin, limited meats. It's not that meats all are not all bad, but the more plant-based eating you're doing, usually it offsets by eating fewer animal-based products. Those are all things that absolutely do contribute to lower LDL, lower triglyceride, lower blood glucose, which all of those things are nothing is specifically anti-inflammatory. Nothing is even, some things are pro-inflammatory, like I say, in the sort of processed area. carbohydrate side of things. But it's kind of the totality of it that leads to being anti-inflammatory. And definitely the supplements that people sell for a lot of money on the internet are not evidence-based. Maybe they will be in the future, maybe, and I hope we spend time and energy really truly studying what are some foods and supplements and additives and things like that that do produce these effects, but we don't have any of that information at this time, so nothing is shown to do that.
Okay. Oh, great. We have another question from Gloria around alcohol use. It didn't show up on the slide.
Oh, yeah. Mm-hmm.
Okay. Do you want to speak to that?
Yeah. So it is. Yeah, it's right. It's certainly alcohol is not. It doesn't sort of come out as a specific risk factor for cardiovascular disease exactly. Like it's not that it's a very linear relationship like some of the others. Partially because, again, the evidence lags behind a little bit in time. So I suspect we're going to get there. For sure now, when we're sort of doing a risk calculator, we will ask about alcohol use. And everyone, myself included, wants an exact number of, like, Francine, you said, like, but like, how much exactly am I allowed to have, right? Like you want it like a little aliquot given to you, like, and say, like, this is safe. We don't have that. Lower is better, just like almost anything else. So that's kind of where we are with alcohol. But certainly, one thing it is not is protective. There were decades of sort of not evidence, suggestions that red wine was protective of the heart. It is definitely not. It's usually a symbol of all these other things that are protective of the heart, and red wine is just the one of the associations. So yeah, it's definitely not protective. Don't drink your red wine for your heart. Drink it if you want to enjoy yourself. Enjoyment is always really good. Not in excess for sure. And I suspect we'll be revising guidelines as such.
Okay. And so building on that, what about THC or CBD?
There's not a lot of evidence actually about that. So of course we know that some of the CBD, THC, some of those kind of relaxing effects and those things, of course, and there's some what we call vasodilatory, which means your blood vessels open and relax, which causes blood flow, which is good. Those are all very good things. Many of those types of drugs over time and with sort of more chronic use do become sort of pro-anxiety inducing. Anxiety does activate inflammation for sure. So, again, it's probably, but there's not tons of evidence. We don't know causally. Again, people who have heavy use tend to have other sort of confounding factors. So we can't just say everything is created equal. CBD or THC use in this group increases risk by this much. It's not that simple from a statistical point of view. Time will tell. Legalization certainly has allowed us to do far more, or decriminalization, I should say, or legalization and decriminalization, both of those things together have allowed us to do far more studies on this from a sort of population point of view. So I would say some aspects are good. Don't go after it for your heart. It may not be as bad depending on in very probably small doses. It's probably neutral.
Okay. Maybe switching gears a little bit, you talked about the fish oil, and you talked about how it's a very specific type of fish oil.
Yeah.
So to help with inflammation. So is this something I can just buy at the grocery store, or is it something that has to be?
No, it's a prescription. Yeah, it's a prescription, unfortunately. And again, that's part of the challenge, is that it's not something, it's actually, there's lots of challenges with studying precise things. If you want to know exactly, like just as I described with CBD or red wine, there's certain elements it's really hard to tease out in large studies. So the fish oils that we can get either from foods or even at the grocery store or pharmacy or health food store don't have that high purity and don't have that sort of, in this particular one, there's actually also a slight modification that probably makes it more stable going into the bloodstream. That's the kind of the guess. So that's kind of, but I think where we're moving for some of these things, it's the epidemiology, meaning the population studies that suggest things like fish oil. Those are, the reason for that probably is that enough of this kind of modified one does get into the blood for certain people. And this drug has kind of mimicked that by like making it in that way. It's still derived from fish. It's just, modified slightly. So yeah, unfortunately, we can't just, again, most like, oily and fatty fishes are still good for the heart. So it's not to say those are by any means not that those are highly recommended from the guidelines point of view, but buying it off the shelf at the drugstore isn't necessarily going to give you the same dose of these really good fish oils that this type of drug can get, unfortunately.
Okay. All right. Thank you. So some of the other questions that people have are around, again, food choices. So high histamine versus low histamine food, where we stand these days on eggs and butter, that's still causing bad high cholesterol. We get conflicting messages, certainly in the popular press.
Yep, yep. So some of this is, if you're interested in those kinds of things, some of this is like, food policy related too, like different advocacy groups, right? Kind of advocating for their food group versus another, and certainly, things like dietary sources of cholesterol when eaten in high amounts can increase blood cholesterol. That's not the majority of where our blood cholesterol comes from. It's not like into the stomach and then into the blood. That's not how it's regulated. There's lots of other steps in between. Again, high levels of sugar do elevate cholesterol indirectly through other mechanisms. So it isn't, again, it's kind of that holistic point of view. Eggs on their own are not bad if you're the type of person who's eating 12 eggs a day and only red meat and only probably together those things will absolutely. It's pretty uncommon to recommend completely eliminating eggs, for example. That would be probably not something that would be recommended at this point, but it's not it's all about what the totality of your day is like. If you're generally eating plant-based, whole foods, and some of those whole foods include butter and eggs, that is still on totality much, much better than, avoiding eggs altogether, but having, highly processed foods that might sort of not contain cholesterol, but have the reduced, impact of having potentially high inflammation for other reasons. So, and again, like just to like not to get on a soapbox, but we haven't funded these type of especially nutrition-based studies for whatever reason. Like it was easier, faster, maybe more sexy to find a drug. Like we wanted drugs. We wanted to find cures, drugs, etc. So we sort of didn't fund the research that was looking at some of these things. We just went for the money, and just went for the drug. So I think everyone's at a different place now. Like I think as society we recognize like, oh, maybe the solution actually exists in the things we do every day versus I'm going to discover the pill that's going to cure it all. So both of the approach, don't get me wrong. I'd say one of the hardest things I think for people to hear is that when they, and this happened to my mom, like she was doing everything right. She was exercising, her blood pressure was under control, her her eating was amazing, she lost weight, she's doing all this stuff, and like still she had higher cholesterol than was recommended. Like still she was having, and she kind of, and at a certain point your lifestyle can only do so much, and that's where medicine comes in for sure. So don't ever think that lifestyle alone, and if you just worked harder at it, that you can get there. It's that for some people that works for sure. Others, it doesn't matter what they do. And for others, their lifestyle could be the absolute textbook worst lifestyle, and they don't have a single elevated risk factor, right? They just have like everything is a clean slate. And so it's amazing what our genetics do, and we can't control it all. And usually it's an additive effect, and nobody should blame themselves if they're like doing it and just think I got to do more of it, because at the end of the day, it's a combination. So take all the tools that are available in the toolbox. That's kind of the way that I tell people. Don't just don't beat yourself up about it. There's lots of stuff you cannot control.
I think that's a great place to land it, really. It's that whole idea of living a balanced life and in moderation, I think is all really powerful advice. I heard somebody say that 80% of cholesterol is genetic and only 20% is affected, or 85-15. It's something like
Yeah.
that. So
Yeah.
it's, I mean, yes, make good choices, but also don't beat yourself up because there's a lot that you can't, that there's a lot on that non-modifiable risk factor part of the balance sheet. So I just, with that, I think, go ahead.
I want to just share
Yeah.
one thing, if you don't mind, only because I actually had my cholesterol done this week. And even I was above 3. And I say that like you guys don't know me, but I mean, this is my life, right? Like I think about cholesterol constantly, and I do all the things, and there I was like, what? And my doctor was like, it's not that high. And I was like, it is, so
These are someone else's results.
I know, right? It just, anyway, so yeah, like I don't want to say even me, but like, you when you know everything there is to know and you do all the things that you know to do, your body has a different idea, right? So
Absolutely.
All right. Thank you guys so much again for joining us today. Francine for sharing your story. Katey for the insights. Really, really helpful and informative. Thank you. Over to you, Jenny.
Yes, thank you all.
Thank you so much, yes, to Francine and to Katey and to Anne-Marie for moderating today. We really appreciate you taking your time out today. Also, we know that we didn't answer all of the questions. You guys had so many wonderful questions, so thank you so much for that. I will be sending all of your questions to Anne-Marie and Francine for answering, and then we will add somewhere, email or what have you. I'll figure that out, but we will get you your questions answered and give us a little bit. All of the recordings for the E3 series will be available on HeartLife's YouTube. Thank you so much, and we hope you have a wonderful rest of your Friday and a wonderful weekend.
Thank you.
Thank you all.
Thanks, everyone.
Bye.
Bye.
Bye.